Okay, I think that most people have joined the room. And so I would like to welcome everybody to our now second annual Virtual Lung Cancer Patient Summit. For those of you who don't know me, I'm Stephanie Snow. I'm a medical oncologist in Halifax, Nova Scotia, and I'm the president of Lung Cancer Canada. And I'm thrilled to welcome you all here today. We had a great summit last year, and I suspect that we may even outdo the excellent content and interaction and being together, albeit virtually this year. I'd like to mention and thank our sponsors who have made this evening's event possible. And those include Amgen, AstraZeneca, Bayer, Bristol Myers Squibb, EMD Serrano, Jazz Pharmaceuticals, Eli Lilly, Merck, Pfizer, Roche, Sanofi, and Takeda. To get the ball rolling, I'd like to start off by introducing our host for the evening. Our host is going to be Mr. Stephen Salos. Mr. Salos, or Stephen, is a 64-year-old man, and he was born and lives in Southwest Nova Scotia, and I'm proud to say that he's one of my patients. He's married to his wife, Janet, and they have 3 adult children. He's a retired electronics technician and a community volunteer for several local charities. He does also a lot of work for Lung Cancer Canada, and it's his family who are responsible for the great design on our Hope Army t-shirt. He enjoys outdoor hiking, biking, sliding, kayaking, and playing with unusual curves. Next, I'd like to introduce Shem Singh. Shem is the executive director at Lung Cancer Canada, and he joined the organization in September of 2013, so 20 years ago. He's been here since the very beginning. He's held senior positions in large multi-jurisdictional non-for-profit organizations. And Shem's going to start off the evening by taking us through 20 years of Lung Cancer Canada.
Welcome, everybody, and thank you for the kind introduction, Stephanie. I don't mean to correct you, but I've been here since 2013, so for 9 years of the 20. But at the same time, I'm very pleased to be here, and just trying to work with technology. So forgive me for just a moment. But anyhow, I'd like to start off by asking a question. Have you ever found yourself thinking about something when all of a sudden a song pops into your head? I think we've all been there. And as I was thinking about today's event, a line in a famous song kept coming to my mind. Many of you will know where I'm going with this, but for those that are not familiar, the song begins with, "It was 20 years ago today." But as quickly as that line enters my mind, another one follows, and it goes something like this: where hope found its home, a place to stay. I won't compare myself to the Beatles, but I like that line. It's a reflection of what holds true, and that Lung Cancer Canada was built on a foundation of hope. It was 20 years ago when founders Magdalene Winterhoff, Dr. Yi Ung, and Ralph Guda, with the support of a few honorary members, formed what was then known as ALCASE, the Alliance for Lung Cancer Awareness, Support, and Education. It was a humble beginning, and I have asked someone very special to help share the story of what has become Lung Cancer Canada and how this organization came to be. I would like to welcome one of Lung Cancer Canada's founders, Ralph Guda, to say a few words. Ralph?
Thank you. I think you were good enough to introduce me because nobody knows who I am. I'm very pleased and proud to say that a little bit over 20 years ago, I decided to create something that I called Lung Cancer Canada. The reason, sadly, was that I lost my wife a year before to lung cancer, and in her memory and honor, I decided to do that. So Lung Cancer Canada has been officially recognized and registered slightly over 20 years ago. I was very lucky to have the support and help of two extremely dear friends who are both at the time working for Sunnybrook. Magdalene Winterhoff has retired since, and Dr. Yi Ang is still active he specialized in lung cancer, and I am in very close contact with him. The idea of creating Lung Cancer Canada is to make sure that people are aware that we care. We don't have a regular call up to particular individual and so on, but thanks to the organization now, they have their own way to approach as many people as possible. The Lung Cancer Canada is, in our opinion, very well known, but in the opinion of the majority of the people in the world or in Canada, they don't know what we are talking about. So it's very simple. It's an organization, small as it is, consists of 3 people. I am one of them, and we try to not only spread the cause of fighting and recognizing Lung Cancer Canada, but to help in whatever area we can. There is nothing in specific that I could mention or tell you that we do, but one of the things, we are in contact with many lung cancer specialists, doctors, who in turn, some of them refer us to patients with lung cancer. And this very primitive way of doing things has worked for us. We are very proud of what we can do and what we have been doing. And that here, 20 years later, thanks to the good people that are looking after it now, we are still around, we are still known, and hopefully we will spread even much larger than we are. So if you have any question to ask me that you think I could help by answering, go ahead.
Absolutely, Ralph. Thanks so much. I'm smiling with Ralph because he invited me to his home. I'm sitting on his floor. We're trying to use technology the best way we know how.
Yes.
And I think that harkens back to how the organization started.
Absolutely.
It was very limited in its resources.
Absolutely.
And you did as much as you could with
Yes.
what you had.
Yes.
And in truth be told, you did tell me a story of perhaps selling a stamp collection in order to help fund the organization.
I didn't want to mention that, but now that you mentioned, to start anything, you need money. And I had lost my wife at that time, as I mentioned earlier, and she had left a few dollars, and we used them to start Lung Cancer Canada. And I'm sure that she would have been very proud if she was around to see what we did and so on.
She would very much be proud, Ralph. And I thank you so much for your comments.
Pleasure.
We are all grateful for your care and concern, the generosity of self and family, a willingness to share, and your vision to provide support for those affected by lung cancer.
Thank you very much for saying that. I just want to add, if this is going to be spread to other people, that we welcome any and everybody to join us, either by becoming a member with us or to help us financially or morally or whatever. That's the type of organization we are.
Fantastic, Ralph. So thank you so much for being with us here today.
Pleasure.
At 91 plus years old, keeping up the fight,
Yes,
and that's what this
yes,
organization's
yes.
about to
I'm
do.
very proud, and if I live any longer, I will still be active. And if you need anything else, to always be around.
Awesome. Thank you so much, Ralph.
Yeah.
So I'm very pleased and happy to say that when I first met Ralph, he mentioned one thing to me that has always stuck with me every day that I've been with Lung Cancer Canada, and that is, what have you done for a lung cancer patient today? I will always remember that, and I'm grateful for that wisdom, Ralph, that you shared with me. When I started at Lung Cancer Canada in 2013, Dr. Natasha Leo, president of LCC, advised me that they had planned a strategic planning session back in 2012. To highlight where we have come from and where we're about to go, I thought I would share with you some of those findings and outcomes. And all of this against the backdrop of our mission, which is to increase education and awareness of the disease, to support people living with lung cancer and their families, to advocate for improved access to testing and treatments in all provinces and territories, and most recently, increasing funding for lung cancer research projects. In the materials from 2012, there was a summary titled "A Historical Perspective, Lung Cancer Canada's Programs and Services in Prior Years." Amazing piece of work. Of the 3 pages, 2.5 of them described brilliant ideas and initiatives which unfortunately could not be sustained at the time. These included telephone supports to patients and caregivers, awareness and anti-stigma campaigns, podcasts, expanded partnerships, and patient and caregiver seminars. Again, brilliant ideas, but perhaps the timing just wasn't right. However, there were some major successes, including LCC's patient guide and fact sheets. As we move forward, I'm pleased to say that all of those brilliant ideas and the initiatives have come to fruition, and in many cases have been expanded upon. I'll quickly go over a few of those things for you. LCC's peer-to-peer network provides support throughout the country. Peer-to-peer navigators are lung cancer survivors or supporters who can mentor, offer encouragement, advice, experience, and hope to those newly diagnosed or anyone needing additional support through a matching one-on-one and a personal connection. Our new Airways of Hope program provides virtual support from a registered social worker. They can provide help with emotional concerns, bereavement support, financial concerns, and practical day-to-day issues. Lung Cancer Canada's Hope Army is our social media hub for raising awareness. Hundreds of lung cancer patients and supporters fight lung cancer by spreading awareness and education about the disease through their collective voices and actions. By completing missions, the Hope Army has become a force for advocating on behalf of the lung cancer community. Stop Asking the Wrong Question Anti-Stigma campaign is a joint effort between Lung Cancer Canada and the Lung Health Foundation. In its second year, we look to end the stigma of lung cancer and change the conversation. With over 58 episodes, the Lung Cancer Voices podcast is a series where Dr. Paul Wheatley-Price, past president of Lung Cancer Canada, sits with guests to discuss current issues, relevant topics, and patient experience. Since 2020, the What's New in webinar series has also been a popular series moderated by Dr. Wheatley-Price, focusing on emergent trends in lung cancer. Over the past several years, LCC has partnered with dozens of aligned organizations in support of the lung cancer community. Most recently, we partnered with the Lung Ambition Alliance, Give a Breath 5K, the Lung Health Foundation, the Canadian Association of Retired Persons, the Lung Association, Right to Survive, Canadian Cancer Survivor Network, CanCertainty, Cancer Action Now, and numerous industry organizations. Each year, Lung Cancer Canada's Medical Advisory Committee increasingly advocates for access to the best and newest treatments for Canadians with lung cancer. This work is exemplified by the high regard in which our numerous submissions are received by CADTH and INESS. The Medical Advisory Committee also develops LCC's outstanding patient guide, which continues to be the essential resource for lung cancer patients, their caregivers, and healthcare professionals. Since 2014, the patient guide has seen its format expanded, the availability in additional languages, and its distribution has increased 5-fold since 2014. With tremendous and generous support from their respective families, Lung Cancer Canada has established the Jeffrey Ober Memorial Research Fund, Kayla's Angel Fund, the Lindsay Gambecki Memorial Fund, and the Elizabeth Dessereau Memorial Fund. In terms of patients and caregiver events, we annually host between 2 and 4 in-person or virtual patient events, along with the Evening of Hope, our stakeholder briefing, and additional legislative events. We support dozens of fundraising events, from bonspiels and hockey tournaments to runs and even yoga sessions. So that summarizes a lot of what we've been doing over the past 10 years. But in 2017, we decided to hold another strategic planning session. And it was very apparent at the time that the organization's rapid growth had outpaced its governance and resource models. While the programs and initiatives were well received, we were at a point where we needed to place attention on governance and sustainability. With that said, we embarked on a governance and policy review. LCC's board was revamped, its committees expanded. Internally, we added more skills and experience to our staff complement. And throughout this time, we also created additional supports for a community that faced many challenging unknowns due to the pandemic. Now to the present in 2022. This past year also started with a strategic planning session where the outcomes included sustainability of all of the great programs we do in light of an economic downturn, increasing LCC's political capital and advocating for access to testing and treatments, and outreach, making an impact on rural and remote and unserved communities with our supports. So what is on the horizon for Lung Cancer Canada? Well, there's a lot. A targeted expansion of our programs and support hubs throughout the country, the development of regional specific in-person patient and caregiver events, support of the XL program where lung cancer patients can receive physical and mental wellness sessions, both virtually and in person, the expansion of the podcast series to include additional language options, a new website that will provide regionally specific information, up-to-date resources, and new tools for lung cancer patients, caregivers, and healthcare professionals, an expansion of the Lung Nurses Network, an updated patient guide in multiple languages and formats, a dedicated internal resource for public affairs and communications, and another massive emphasis on supporting research, for which I'm very pleased to announce the establishment of the Lung Ambition Awards, a joint initiative between Lung Cancer Canada, the Lung Ambition Alliance, and AstraZeneca Canada. With the goal of improving patient outcomes, the Lung Ambition Awards are designed to support research that will help address key gaps in lung cancer care and help drive meaningful improvements to the patient pathway. We will be awarding $100,000 a year for the next 3 years. We have listened, and with each day, the voices of lung cancer patients, their families, and caregivers strengthening our collective resolve to do more. In many ways, LCC is a family. We miss those that we were fortunate to work alongside with. We're grateful to those that we have yet to meet, as the stories told and untold motivate us to continue forward. In closing, on your screen, there's a picture of Lung Cancer Canada's Grove at ET Seton Park. As we mark LCC's 20th anniversary, I would like to offer our gratitude to Ralph and his family and LCC's founders and members. I would also like to take this opportunity to acknowledge that we've been brought together because of the thousands of patients, families, caregivers, volunteers, and partners who have conveyed their hope to our Lung Cancer Canada family. It was 20 years ago today where hope found its home, a place to say. Thank you very much.
Thank you, Shane, for what you did. It's very good.
Thank you, Ralph.
Thank you, Shem, for your presentation very much. And Ralph, it's an honor to meet you, even if it has to be over the airwaves like this. I've heard of you in the past, and you are a rock, I know, with from the beginning with Lung Cancer Canada. So thanks for what you have done.
It's nice to hear your voice and talk to you. Hope we get together one day soon.
Oh, that'd be fantastic.
Yes.
So hello to everyone. I am Stephen Salos. I am a stage 4 lung cancer patient living very well with lung cancer, despite my condition. I have a few housekeeping items which I'd like to bring up. There will be a question and answer period after each speaker, so please hold all your questions until then. You can enter your questions in the chat or raise your hand, unmute, and ask. Our next speaker is going to be Dr. Paul Wheatley-Price. Dr. Wheatley-Price is a medical oncologist at the Ottawa Hospital in Ottawa, Ontario. He's an associate professor at the University of Ottawa, an immediate past president of Lung Cancer Canada. Dr. Wheatley-Price is also the host of Lung Cancer Canada podcast series called Lung Cancer Voices. It's for patients and caregivers, and I highly recommend checking this resource out. There is much to hear from him and much to be learned from the various patients and people that he does interview. Paul will be speaking on new treatments in lung cancer. So over to you, Paul.
Thank you, Stephen, and Sham and Stephanie and Ralph. I'm happy to be here. That is an awful photograph of me, by the way. I have to say, I have to send in a new one. So it was 20 years ago today. So Shem's got me back to my roots of the Beatles. So it's wonderful to be here. It's certainly a thrill. You're such a lovely audience. We'd like to take you home with us.
Oh, no.
I'm a bit of a Beatles fan. But I was going to frame this little presentation for the next few minutes on a different song. Yeah, so Stephen has been a guest on the pod, and if you would like to, please do sign up for Lung Cancer Voices, and it's now in French as well. So Dr. Nathalie Daboul in Montreal is now going to be running our Lung Cancer Voices podcast for a francophone community, which has been a big drive for us in the last few years to try and support more patients in Quebec and New Brunswick and francophone communities across the country. I think, Winky, can I have the next slide? Right, so yes, a different song that I thought I'd theme my just short presentation on, 12 Days of Christmas coming up. And so I am going to just, in a whistle-stop tour, try and highlight to you 12 things about lung cancer that are on our hearts and minds this year, some advances in treatment and some challenges. So the first one, please, to the next slide, 12 drummers drumming. So lung cancer survival, to start on a positive note, is as high as it's ever been, which is fantastic. And we go to the next slide, and I'll just put some numbers to that. So it's not all good, because lung cancer, unfortunately, remains the #1 lung cancer for most of the wrong reasons. It is the most commonly diagnosed cancer. The Canadian Cancer Society, if you want to see these numbers, you can get them on their website. But 30,000 Canadians in 2022 predicted to be diagnosed with lung cancer, and even split for the first time, 15,000 men and 15,000 women. And while that represents about 13% of all lung cancers diagnosed, it represents about a quarter of all cancer deaths, because lung cancer, unfortunately, it is the most fatal cancer. However, one of the ways we measure survival or the success of treating a disease is how many people are alive 5 years after a diagnosis, and we're now up to 22%, and that's not very much. 26% among women and about 19% in men, 22% overall. So that's, as you can see, we've got an awful long way to go. If we compare that with, say, prostate cancer is over 90%. You know, 10 years ago, when I started my involvement with Lung Cancer Canada, and Shem was just about to start his involvement, we were at about 13%. So there's been a huge improvement in the last decade. And that's due to things like targeted therapies, immunotherapies, better testing, better access to treatments. And I think we're going to see over the next 10 years, I would hope, at least a similar increase, and I suspect a lot more, because of things like screening and new treatments. I've seen a question pop up about that 22% is for all stages combined. So the next slide, please. Winky. So this looks at, I'm going to try not to show too many sort of graphs and things, but this is, I think, a nice one. This shows death rates from cancer, from common cancers in Canada, color-coded by cancer and by gender. And the top two are lung cancer. So that light blue is lung cancer in men, and the purple is lung cancer in women. So there is the sort of positive and negative in a picture. The negative, of course, is that they're the two most common causes of cancer deaths in Canada. But the positive is they're both clearly reducing. That death rates in men have been falling for a number of decades now, and in women they weren't actually. In Canada was struggling compared to peer nations, but are now starting to drop quite consistently. Okay, so next slide, please, Winky. So no, back one at a time. Okay, so number 11. For those of you who know the song, 11, Pipers Piping. Lung cancer screening. So now we can go to the next slide. So lung cancer screening, so this is normally CT scans to try and identify lung cancer before it spreads and before it's an advanced stage, to catch it at stage 1 or stage 2, which are small tumors, which generally can have got a high chance of cure. And the Canadian Partnership Against Cancer, or CPAC, is Crown, kind of like a bit like a Crown corporation, and they produce the National Cancer Strategy, and this goes by decade. So the recent one is 2019 to 2029. And unusually for them, they specifically highlight a specific test for a specific cancer, and that is lung cancer screening as being a priority for our national strategy. And then they published an update on lung cancer screening and what's going on in the country just a few months ago. And if we could go to the next slide, there's a map of what's going on. And I won't drive you through this entirely. Gray is at least where something is going on. So Ontario has a program, British Columbia has a program, Quebec has a pilot program. The other provinces have at least some projects or plans to implement programs. Unfortunately, at the moment, the territories are lacking and are falling behind. So if we go to the next slide, that's just in a graph format. So fully implemented over on the right is BC. So that's good for BC. Ontario, we do have a program. It's here to stay. It's not fully implemented in the sense it's not available across the province yet, only in certain places. Quebec recently have opened a new program or pilot program. And as you can see, Alberta, Saskatchewan, Manitoba, and the Atlantic provinces are planning for implementation, even if it's not there yet. So this is a big issue for all of us here. If you would like to get involved, we really would like your help. We've been banging on the doors of federal and provincial politicians, Dr. Snow, myself, many others, to make this our #1 ask, that screening be implemented. And this is maybe the biggest opportunity to improve that survival rate by diagnosing things earlier. And I'll come back to that in a bit. Okay, that's 12 and 11. They get a bit quicker, you'll be pleased to know now as we go on. So 10 Lords are leaping. Small cell lung cancer. So this is less common. It's about 15% of lung cancers and is a particularly aggressive type of lung cancer. But good news is there is a new treatment for the first time in a long time. Immunotherapy drugs, which stimulate people's body's immune system to fight the cancer. When we add that to chemotherapy, we know that that now is more effective and can certainly help a proportion of people live a lot longer with small cell lung cancer than we have ever seen. We've known that this treatment has been effective for 2 or 3 years, but it was only earlier in 2022 that finally there was a national pricing agreement agreed. So this is now rolling out across the provinces and is available just about everywhere in the country. So good news for small cell lung cancer. Next, please, as we move through our 12 days of Christmas. So 9 ladies dancing, 9 dancers dancing. Forgot my song. Chemotherapy is okay. And I just wanted to put this in. This isn't really a headline of anything new from 2022. But if we could go to the next slide, please, Winky. Sometimes I think that when we talk about new treatments like targeted therapy, which I'll come on to in a minute, which are often pills, or immunotherapy, and we talk about them sometimes, and we're guilty of it, that, oh, that's much better than chemo with all those horrible side effects. But the reality is that chemotherapy these days is not so horrible as it used to be. The anti-nausea drugs are much better. The chemotherapy drugs themselves often have fewer side effects than some of the older chemos. We're very comfortable prescribing them and managing them. So if you are facing chemotherapy in your future, if we go to the next slide, that idea that like you might see in the movies, where if you have chemo, you've got your head down the toilet for weeks on end, is just not the reality. And chemotherapy is actually, for many people, quite well tolerated. Okay, that is number 9. 8 maids are milking. So now this is getting onto sort of targeted therapy. So by this I mean that when Ralph and Madeline and Yi founded Lung Cancer Canada back in 2002, there were not subtypes of lung cancer. You had small cell lung cancer maybe, or you had non-small cell lung cancer, and that was about it. But now it's far, far, far more complicated, but far, far, far better because of the advance of science. So I'm not going to try and teach you molecular biology in the next 60 seconds, but non-small cell lung cancer, which is the most cases, 85% of lung cancers we call non-small cell lung cancer. And we started by dividing them into some subtypes based on their appearance under a microscope, adenocarcinoma and squamous cell cancer. But now with what we call next generation sequencing or mutation testing or precision medicine, genomic medicine, it comes in many different names. We can essentially identify the fingerprint of the lung cancer, the DNA profile of the lung cancer. And this has led to identification of many different subtypes, each of which can have a specific treatment. So that's why we call it targeted therapy, because the drug targets the specific type of lung cancer. And this has revolutionized lives for so many people. So could we go to the next slide, please? So of course, to know what the subtypes are, we need to be able to have the facilities and the capacity to do the testing. And so comprehensive cancer testing with this thing called next generation sequencing is now largely available for all lung cancer patients across the country. There is funding in different provinces, which run through different mechanisms because we have a provincial healthcare system. But really the good news is that we, in 2022, I think we are largely there at the point where patients can get access to next generation sequencing. We still do have challenges in timeliness of that, but this is really has been, I think, ongoing forward steps in 2022. Okay, next one, marching towards the holidays. So 7 swans are swimming. I'm just going to focus on one of those subtypes from that sort of pie chart, which is called KRAS G12C. And for those of you with lung cancer who are on the call, this may not apply to you in particular, but maybe it will apply to some of you. Could we go to the next slide, please, Winky? So KRAS G12C, this is kind of the new kid on the block, if you like, the newest subtype that we've got kind of excited about. And actually, it's fairly common. When we look at some of these rare subtypes, we're seeing them in 1% of people with lung cancer, 2%, 3%, even 0.2% in the rarest one. But this KRAS G12C, it's a bit of a mouthful, but actually it's quite common. It's maybe 15% of cases, and that represents, well, that represents thousands of people a year. And there is now a pill which can help treat this, and it's called sotorasib. And there are other ones that are in development, some far on in development. There's one called adagrasib as well. And sotorasib is the first one, though. And Lung Cancer Canada has been advocating for the approval of this as recently as September, when this drug was filed for regulatory approval, and it's working its way through that process. And we just learned in September at a conference in Paris, the big European Oncology Conference, that sotorasib seems to be clearly better than chemotherapy. It's more likely to shrink cancers, more likely to keep the cancers from progressing for much longer. To be honest, it was not quite as good as we were hoping for. We were hoping it was going to be even better than it is, but it looks like it's the first drug which is really going to make a difference, and there are some following behind it that look, at least provisionally, even better. Okay, we're about halfway through. Six geese are laying. Ask your doctor what subtype you have. So this is important. So we could go to that next slide, please. I think self-advocacy is not a skill that everybody has, but if you do, or you can advocate for someone you love who is going through this, it is really important to know what type of lung cancer you have. Your oncologist should be taking care of this. They should be addressing this with you, because treatments really depend on the subtype, and we need to know. So on the right, that one where it says targeted therapy are all these different subtypes, and you don't need to learn them. There's no quiz at the end. There's no, unfortunately, free Lung Cancer Canada swag for getting getting the colors and the drugs right. But each of those boxes on the right represents one of these different subtypes, and then below it, the names of the drugs that we can often prescribe for patients with those subtypes. Many people don't have one of those subtypes though, and then we go to the left-hand panel where we're still using chemotherapy, and that's the group where these immunotherapy drugs have made a big difference as well, and I'll come back to that in a minute. So it's important to know what subtype you have. Okay, next slide, please. Right, or just finally on my 6 geese are laying, I think that's what we're up to, is access sometimes is a challenge, and there have been some setbacks this year. There's one drug which failed to negotiate a price with nationally, which was really disappointing. That's the drug for BRAF lung cancer, particularly disappointing because they did negotiate a price for the same drugs for melanoma, a type of skin cancer, but somehow failed to with lung cancer. So we're investigating that at the moment to see if we can get that reversed. But there has been progress for approval of many of these drugs. When we apply, when we look to get drugs approved, as the Lung Cancer Canada community, we provide submissions to support those applications, and we are always looking for people who have taken these drugs to provide input as well. So if you are looking to help, or you know people who might want to help, please reach out to us. Winky is your contact. I hope, Winky, you can put something in the chat if I've got that wrong. But you can also email me or Dr. Snow or Dr. Ros Jurgens, and we can help. Okay, next slide. For time's sake, I better get a wiggle on, otherwise there's probably a Beatles line that'll get me kicked off. So number 5, immunotherapy, 5 gold rings. Immunotherapy, so let's go to the next slide. Right, so the idea of immunotherapy is, if you imagine there's that in that little picture, those purple things with the swords, that's like your immune system trying to go and destroy the cancer cells, which are the sort of scaredy looking white blobs at the other end of the road. And in the past, there have been barriers to that. The immune system has not been able to attack cancer cells because there are barriers. There are chemical barriers. We call them checkpoints, and hence this picture. And that's why cancer, one of the reasons cancer can survive, because it evades our own body's immune system to destroy it in the way that your immune system might help you fight a common cold. So this new group of drugs called immunotherapy, we call them checkpoint inhibitors because they get rid of the checkpoint. And so they open the path for the immune system to fight the cancer. And we've known for a while that immunotherapy is very valuable in a number of situations. In fact, just earlier with one of the 11th day of Christmas, maybe, we know that immunotherapy helps people to live longer with small cell lung cancer. The newest thing from 2022, and I put a Canadian flag because there's a lot of Canadian leadership in some of these research studies, is for people now with the earlier stages of lung cancer who may be going to have surgery. It looks like we can now start to give immunotherapy either before or after surgery with a much better chance of preventing the cancer from coming back, or even improving the outright cure rate. Those are working their way through the regulatory processes, but as of today, we can certainly give immunotherapy before surgery for people who meet the right criteria. And looks like it's probably been the hottest topic in the lung cancer scientific community in 2022, is the emergence of immunotherapy for sort of these early stages of lung cancer. Okay, next slide. We're on to the countdown. 4 calling birds. So immunotherapy, again, So immunotherapy, early stage, that I've just mentioned, but if we go to the next slide, the truth is at the moment that still a majority of people, or at least 50% of people diagnosed with lung cancer, it's already spread at the point of diagnosis. It's stage 4. Now, if we go back to the 12th day of Christmas and screening, or was it 12th day or 11th day? One of those days. If we can improve screening, we'll see that change. We'll see less than 50% at stage 4, and we'll see more and more people diagnosed at an early stage where the cancer is curable right from the outset, we hope. But people who are diagnosed with stage 4 lung cancer, that doesn't mean there's no hope, because immunotherapy, targeted therapy, really is helping many, many people live many, many, many years now of good quality and quantity of life. And just at that Paris meeting, we received some updates from some of the earliest studies of these immunotherapy drugs that were happening 5, 6, 7, 8 years ago. And what's really exciting is to see the proportion of people with stage 4 lung cancer who are now alive and well without any progression of their cancer years on after having immunotherapy, and in some cases years after finishing immunotherapy. So a standard course might be 2 years, and now we're seeing people alive and well years after that, and I see people like that in my practice every week. Now, it doesn't work for everyone. That's I'm afraid a cold truth, and for some people it doesn't work as well as we would like it to, but it is been a huge step forward. Okay, number 3. Okay, a little less positive, I'm afraid, this one, but I think we all need to get a dose of this from the 3 French hens, that equity is a challenge for us in Canada, and there's no point us looking to other countries and their problems when we do have issues that we need to deal with on our own doorstep. So the next slide will just highlight some of those. Well, actually, it really just highlights the issue. So I've already shown you lung cancer screening is variable across the provinces and doesn't exist in the territories at the moment. NGS, that next generation sequencing testing, the lung cancer fingerprint, is actually a lot better, and is really quite widely available now. But the timeliness of getting that test still varies. Affordable medications in a timely manner, and I sort of hinted at that earlier, that some of the drugs this year have not been approved. Others have. Sometimes it seems really inconsistent as to why one drug is approved and another one isn't. And so there's a lot of work that we do at the Medical Advisory Committee under the leadership of Dr. Juergens to really sort of fight for that. Our Faces of Lung Cancer report this year, you can get this on the website, and maybe Michelle could put in a link to that. Is we title it Equity in Lung Cancer. How do we navigate that path forward? And in that Faces of Lung Cancer report, Dr. Christian Finley, who's a thoracic surgeon in Hamilton, writes a whole report on this. Dr. Finley was also the lead author of a paper a couple of years ago called Equity in Lung Cancer, produced by the Canadian Partnership Against Cancer, which identified that people in rural communities, people from lower socioeconomic statuses, people from indigenous communities do not do as well with lung cancer, and we have to tackle that. So equity does remain an issue which we are fully aware of at Lung Cancer Canada, and really pushing hard on. Okay, 2 to go, I think. 2 turtle doves. I almost forgot my words there. Targeted therapy is also now available for early stage lung cancer, or at least in certain cases. So I talked about immunotherapy for people who are going to have surgery. Well, so specifically, and we can go to the next slide, specifically, there's a subtype of lung cancer called EGFR. Can we go to the next slide, Winky? There it is. So EGFR lung cancer, more commonly seen in people who've not been exposed to tobacco. It's about 13% of lung cancer cases. If you're in British Columbia, it's more common. If you're in Nova Scotia or Newfoundland, it's less common, but it's about that. And there's a drug called osimertinib, which is a once-a-day pill. Sometimes some people know it as Tagrisso. And for people who've had surgery to remove the lung cancer, and this applies to someone in my family, the Tagrisso significantly reduces the risk of the lung cancer returning. And I promise not to show you too many scientific graphs, so I've only put this one in. This is what we call a Kaplan-Meier curve. And what it means is you take two groups of people who have two different things going on, and then you follow them over time. And so in this case, this is all people with EGFR lung cancer who'd had an operation. The group with blue received Tagrisso, and the group in the yellowy green color didn't. And over time, the yellow line is dropping because people are having recurrences. And the blue line is dropping much, much more slowly, or initially hardly at all, because the Tagrisso is preventing those recurrences. And again, in Paris a couple of months ago, we received more update that this really seems to be working, and it is now starting to become publicly available in provinces across the country. So that's good news. And finally, number one, partridge in a pear tree. So this isn't really a new thing. It's really just to kind of highlight hope, which I think you probably sensed from Stephanie and Stephen and Shem, that hope is what we talk about here. And it's not pie in the sky hope here. These advances with survival rates already going up faster than we've ever seen, with so much room for them to grow as screening rolls out and more immunotherapy rolls in and more of these subtypes are identified and those treatments become available and improved. We're going to see more and more and more and more and more people live well with good quality and prolongation of life and cure rates. And so whether it's Hope Army or Hope is Here, which was our Vancouver summit from a couple of months ago, or our annual Evenings of Hope, or the Airways of Hope, or Hope Unites, we are really talking about hope. And later on in the evening tonight, there's a whole presentation on really the scientific basis of hope and how to manage hope. So really would encourage you to stick around for that. And I think I went a bit over time, sorry, but that's my end of my slides. Happy to take questions. I think Stephanie had my back there and was answering some questions as they came up. But Stephen, might pass this back to you?
Sure, that'd be fine.
Oh, okay, Stephen.
Or Michelle?
I was just going to say we're just going to pass it on to Michelle. She's going to facilitate questions and answers.
Yes, so those of you who don't know me, my name is Michelle Wright. I am the coordinator of patient support initiatives here at LCC. And yes, Dr. Snow has been taking care of the questions in the chat. So if there's anyone that would like to ask a question live, please raise your hand. You can do that at the bottom of your screen or in the chat. You can also put your question in the chat. So we have one. If your PDL is less than 1, is immunotherapy sometimes an option?
Yes, it is. There was one of the slides where I had all those different sort of colored boxes of our like our 2022 treatment algorithm. And so what we learn, and in fact we learned more from the Paris conference this year, is for people whose PD-L1 level is low, and that's we classify PD-L1. So I should go back. PD-L1 is a little chemical and it sits on the cancer cell. So if my fist here is a cancer cell, it's a little chemical that sort of pops up through the surface of the cell, and sometimes all the cancer cells have it, and it would be 100%. Sometimes none of them. It would be classified as less than 1%, and often it's somewhere in between. So the higher the PD-L1 level is, the more likely immunotherapy is to work on its own. But for those where the PD-L1 level is lower or less than 1%, immunotherapy, when added to chemotherapy, seems to be clearly better than either one of those two on its own. So we often give them in combination. There is a bit of a move, in fact, also approved in 2022, but I didn't touch on it here, but particularly for PD-L1 less than 1%, so those where this chemical isn't there at all, to give 2 immunotherapy drugs called nivolumab and ipilimumab. together with just a short course of chemo, that also seems to be another approach. So if your PD-L1 level is low, you should still, unless there's some other specific issue, you should still be able to get immunotherapy.
And I believe that Ralph has a question. You can go ahead, Ralph.
Thank you. My name is Ralph Cross. I'm from Calgary, and I was diagnosed in 2018 with terminal stage 4 lung cancer. And I never smoked. And I'm also, by the way, on alectinib, and it is a wonder drug. My question is this: under what type of screening regime would somebody like me ever have been screened for lung cancer? Or is screening more focused on people who have, say, an underlying issue like smoking?
Right. Yeah, good question. We get this question a lot, Ralph. So I suspect other people are thinking the exact same thing as you. So screening, so the idea of screening is you're trying to identify a disease at an earlier stage before anyone develops any symptoms, such that you can change what would happen to that person. So you're not identifying it just to say to someone, oh, look, you've got cancer, but it doesn't change how long you're going to live or what the treatments are. You're trying to catch it at a stage where it will change, the treatment will change. So in lung cancer's case, stage 1 or 2, surgery, maybe radiotherapy, maybe add some immunotherapy or sprinkle of this or sprinkle of that, but then done, gone, cured. The screening programs are developed at the moment in lung cancer to try and identify lung cancers in people who are most at risk. And that's calculated as a 2% risk of developing lung cancer. And that generally is in people who are exposed to tobacco. So if you were a lifelong non-smoker, the truth is at the moment you wouldn't have been eligible for a screening program. So having said that, two things. Firstly, we have this existing challenge of, we know screening can work in people at risk, so we've got to make sure that we roll it out and make it available, and then have people who are at risk use that screening program. So that's one thing. The second thing then is, how do we expand that? How do we take it to people like you or people in our communities who don't smoke cigarettes or not exposed to tobacco? And there's a ton of work going on in this, including our first Jeff Ogrum Memorial Research Grant from Lung Cancer Canada was given to a project just to look at that exact issue. And it's really because it's probably, at least at the moment, it's not feasible to put the whole population through a CT scanner. There's just not enough CT scanners in the world to do that. So what that project is doing is asking people to do a simple breath test. So you may have seen stories that dogs can sniff cancer. Well, maybe they can. And because there are chemicals in exhaled breath, and if you get a positive breath test, then that would kind of push you to a CT scan. So that kind of work, it's not there yet, but that's the kind of work that's going on to answer that question, Ralph. Hope that helps.
Great, thank you.
So we are actually quite a bit over time. So I'm going to ask anyone to, if you have further questions, please email them to info@lungcancer.ca, and we will make sure we find an answer for you. Thank you, Paul.
Well, hello, folks, and welcome back. I think our participants are back after our break, so we're fine to go. I would like to introduce Shannon Smith. Shannon is a registered dietitian with Inspire Health, a cancer support agency in British Columbia, where she shares her passion for balanced nutrition in fresh, simple ingredients. And she's going to be speaking to us about nutrition myths. Welcome, Shannon, and I'll let you take it from here.
Thank you so much. Hoping you can all hear me so far.
Yes, we can.
And just checking in, do I have the ability to change my slides as we go, or will you be changing them for me?
Hi, Shannon. I will be changing them for you, or if you prefer to share your own screen, either one's works for me.
That sounds good. I'll just be mindful to say next slide. So you're welcome to change over to the next slide. So I just wanted to start by saying thank you so much for inviting me to join your group today, and to join us from Inspire Health, or inviting us from Inspire Health today. So I'm really excited to join you and feeling very challenged by a 20-minute time frame. So for this next 20 minutes, I'm hoping to give a little bit of an introduction to Inspire Health in case we are new to anyone, as well as nutrition myths and truths in the context of cancer, from the perspective of a dietitian. And just keeping in mind, nutrition is really complex and very personal. And of course, we're here in a group setting, so hoping to touch on kind of the big picture, but knowing, just keeping in mind kind of your own personal paradigm, your reasonings for eating what you eat, whether that be in relation to where you might be in terms of treatment or a diagnosis or other health considerations as we talk through and explore this topic. And I do hope to have time for questions at the end. So ready for the next slide. So I'm joining you from Inspire Health from the West Coast, and I am in Vancouver, which you see in the center there. We're a non-for-profit charity. We were founded in 1997, making this our 25th year, celebrating services being offered absolutely for free. So we receive the bulk of our funding from the Ministry of Health, and allowing us to provide all of the one-on-one and group services that we offer at Inspire Health for free. No referrals are required, and you are able to access our services both in person if you are joining us throughout BC. We have centers in Victoria, Kelowna, and Vancouver, but of course, here we are connecting online. So we also offer both group workshops and one-on-one services through online or by phone for folks across Canada too. Next slide. So here we are introducing you to our approach, and this highlights the patient at the center you see. So we focus on patient-centered care. And that means if you do reach out to connect with one of our clinicians, that first question typically is, how can I help? Where are you at? And also showing just the clinicians that we have on our team here too. So not only a team of dietitians, but also clinical counselors, supportive care physicians, and exercise therapists. And our care coordinators are the folks who would reach on email or by phone if you do reach out with any questions. Next slide. We offer guidance and support for people with a diagnosis of cancer or those at high genetic risk, as well as their support people. Our programs and services emphasize evidence-based lifestyle approaches that enhance the quality of life of adults living with cancer. And each of those different clinical groups all offer both one-on-one appointments as well as group workshops. Next slide. So the nutrition piece. When Michelle suggested the topic of nutrition myths, the very first thing that came to mind for me was sugar feeds cancer, for a number of reasons. So I spend my days at work here connecting with patients one-on-one, as well as in group settings, and I get this question at least once a day, if not 5 times a day. And that's why I think partially it was the first thing that came to mind, but it's also such a vast oversimplification of a very complex connection with little elements of truth. But overall, I would say this is a myth. So sugar feeds cancer, period. Not quite entirely true, not quite taking in the full picture, because there is truth to the fact that sugar is the preferred fuel source for all of the cells in our body. So from our brain to our muscle cells, sugar or glucose is the main energy source for every cell that fuels our body. And so in that, there's an element of truth that sugar also feeds a growing cancer cell, but sugar also feeds a brain cell and provides the main source of energy. And another element of this statement that causes more confusion, I would say, than clarity, is an indirect link from certain sugar-sweetened foods. So at the bottom, you see sugar-sweetened drinks. And we do actually have some good evidence to suggest moderation with sugar-sweetened drinks, but it's a little more nuanced than an exact connection or causation to all forms of cancer growth. So we do see a connection to high intakes of sugar-sweetened drinks to increasing a risk for body fatness or unwanted weight gain. And we do also see a connection to excess body size, to certain increased risks of certain cancer types. And so in that way, there is this indirect link with the sugar-sweetened drinks to increase cancer risks, but it isn't as direct as the sugar taken in from these drinks automatically going to fuel and feed a cancer cell rather than a brain cell. So it's a more indirect link to the lifestyle and the overall behavior that we see associated with sugar-sweetened drinks. And that really brings to light the fact that the nutrient profile of each food really makes a difference with whether we see an associated increased risk of cancer from certain foods or eating patterns, or even a decreased risk of cancer from foods that might naturally contain some sugars. So things like complex carbohydrates like fruit or grains, especially whole grains, beans, or nuts and seeds, those provide the body with very long chains of sugar that the body has to do more work to break down and digest. And with those foods, we don't see an increased association of cancer risk. We actually see more benefit for the body with the nutrients that we also receive from those foods, as well as providing us with really important energy sources. Next slide. So the truths around carbohydrates, sugar, and cancer really looks at the overall pattern. So the types of carbohydrate-rich foods that we choose to eat, being more of those complex carbohydrates, the whole grains when we can tolerate them, the whole fruit, the beans and nuts and seeds that give us the phytonutrients, the antioxidants, the fiber naturally contained that supports the body more slowly digesting and breaking down those natural sugars, as well as the way that we eat these foods. So this image here highlighting not only just having these carbohydrate-rich foods or naturally sweeter foods on their own, but by pairing those with protein-rich foods, or if you can tolerate fibrous fruits and vegetables, the fiber also helps the body to more slowly digest the sugars naturally occurring in those foods as well. And that's what we would refer to as plate balance. So the focusing more on the whole food forms of natural sugars. Just giving a pause for the audio there. I could hear a little background noise. So partially some of the truths around the carbohydrates and sugar of why I wanted to focus on this topic as well is I see oftentimes during active treatment an unnecessary avoidance of foods like whole grain breads or even beautiful oatmeal or other whole grains that are important sources of energy. And that can be challenging to take in energy sources, as well as certain foods like those carbohydrate-rich foods can be very well tolerated during active treatment as well. They can help to reduce the tendency of nausea, for example, if you're able to eat those foods regularly. And so I find this to be such an important topic to try to dispel some of the avoidance around the worries around naturally occurring sugar of these more whole food forms, because they provide the body with such important sources of energy. They can help to reduce side effects of treatment. And when we focus on the whole food forms, we really see more benefit than harm. And thinking of the big picture as well. So what the research and evidence really supports, so some of those large organizations that really look at the large bodies of evidence around sugar consumption patterns, is that a little sweet foods can be well tolerated and can definitely fit into a very cancer protective eating pattern. So the American Institute for Cancer Research, as well as the World Cancer Research Fund, both highlight that the whole food forms and natural carbohydrate sources can be included, and there can be some space for a little natural sweetness. And in fact, our sweet taste bud receptors are very adaptable. So if you are finding that you are drinking larger amounts of the sugar sweetened drinks that are recommended to be more moderate with, a very practical approach can be a slow and gradual reduction. And we actually notice that our taste buds start to adapt to how much sweetness we are used to noticing in our foods. So if we slowly reduce how much of the added sweetener we're having, over about a couple of weeks, you'll actually notice that you find the less sweet tastes more satisfying than you might have the 2 weeks before by gradually reducing. And that can often be a more practical approach than saying, I'm going to cut out all sugars, but just slowly reducing how much is added. That can be a really well tolerated way to just adapt those sweet taste bud receptors. And it's very unique to the taste of sweet and salt. Those are the two that we can adapt. Next slide. So I mentioned I felt it might be challenging to dive in 20 minutes to such a big topic. So I wanted to be certain to leave time for questions near the end, but also to share how you might reach out to Inspire Health if we piqued interest, or if you're curious about some of our group workshops or our one-on-one services. So knowing that we might be connecting all across Canada, I really wanted to highlight our dietetic led group workshops. So each Tuesday, we have nutrition learning workshops. And actually this morning was balancing blood sugars. So exploring those big pieces, those complex carbohydrates, and how we can eat well to really balance that tolerance in the body. So Tuesday mornings at 11 o'clock Pacific time. And we spend about an hour exploring each of these different topics each week, as well as our cooking classes are offered on Thursday afternoons, and they're an hour and a half. You sit back, enjoy a nice cup of tea, and watch the dietitian cook through a few different recipes on a different theme. So this Thursday, I'll actually be leading our plant-filled treats and drinks. So we'll be exploring using those different types of spices and ingredients to use more moderate, small amounts of sweeteners in the treats that might be coming to mind in the coming season. But of course, our counselors, our exercise team, and our physicians also offer other group workshops that are available on a monthly basis as well. And you can find all of these different dates available through our website, which just is at the bottom here at inspirehealth.ca. Next slide. Just giving a bit of a snapshot here too, where you can find those pieces. So the classes and services, you just find that there. Next slide. I wanted to welcome questions at this time.
Oh, so we have our first, hi Shannon, it's Michelle. So we have our first question in the chat, indigestion and flatulence. So I can't tolerate eating too much beans. How would they supplement through enough protein in this situation as a vegetarian? Is there a protein powder that you recommend?
Yeah, so eat too much beans. So thinking about the different types of protein powders, what comes to mind is if you might be in active treatment or not. So if you are in active treatment, I would recommend a really simple protein powder. And depending if you tolerate a whey-based protein powder, those can often be easy to find just with whey or whey isolate that tend to be pretty easy on the digestion. But if you are looking for a entirely plant-based protein powder, just looking for something that has the protein ingredients themselves. So just trying to avoid anything that would have high doses of antioxidant ingredients or high or any added probiotics. So just looking for the protein if you're doing active treatment can be an important consideration. And there are quite a few, of course, out there. So Boost Just Protein is one that comes to mind that I find can be easy to find in a number of different pharmacies across Canada. And then often when we're looking at folks asking that sort of question, I might ask what type of store you'd be looking at. So there's one that I found, for example, Genuine Health makes a plant-based protein powder that's quite simple in its ingredients as well. That's more of that entirely plant-based option.
So next question, Shannon. During chemo treatment, is it okay to take probiotics? Some pharmacists suggested to take it, but some say don't take probiotics.
It's a good question. And it's interesting that you notice two different directions. We err on the side of caution during treatment with probiotics, just knowing that the immune function can be more challenged, and taking large doses of probiotic supplements, I would suggest against during chemotherapy. So you can take probiotic foods, so naturally fermented foods, if your white blood cell counts are looking nice and stable. And that can be a nice way to actually take in smaller doses of those probiotic benefits compared to the supplementary sources that are really, really big doses. So if you include things like yogurt or sauerkraut or kimchi, then those can be good alternatives rather than the probiotic supplements during chemotherapy treatment.
Thank you. So our next question is on muscle loss. Despite exercising and completing treatment, a patient is still having serious muscle loss. Is there a suggestion that you have for this?
Yeah, and that's, I think, something that would be a great reason to connect with a dietitian one-on-one to try to review how much protein you're taking in from your foods. So it is, of course, that balance. If you're exercising regularly, but you're still noticing that muscle loss, then I would wonder if you are taking enough protein in from your diet. And I think, Helen, this might be the same person that asked about the protein powders. A protein powder might not be a bad idea, especially considering if you're not tolerating beans in large amounts. A protein powder could be a nice way to really supplement that intake. Oftentimes a firm tofu might be well tolerated compared to other legumes, but I would suspect that your protein needs aren't quite being met from how much you're having from your diet at the moment.
So the next two questions are back to probiotics. So probiotics, if you're on a targeted therapy or versus IV chemo, and can probiotics help with diarrhea, or are there any other suggestions for diarrhea caused by the medication?
So for the first question about the IV chemo or the targeted therapy, I would still say focusing on fermented foods as a source of the lower doses of probiotic foods rather than the supplement would be what I would suggest there. And in terms of helping with diarrhea, looking at different types of fibers would be something that actually I would look at rather than probiotic supplements. So even thinking about there's soluble fiber and insoluble fiber. So soluble fiber kind of acts like a bit of a sponge and it helps to firm up the stool. Whereas the insoluble fiber, which we tend to get from kind of the skins of fruits and vegetables and a lot of whole grains, kind of creates more bulk and more irritation through the bowels. So shifting towards more insoluble fiber being a little bit on the lower side and increasing that soluble fiber food source. So that would include things like oats and oatmeal, peeled cooked potatoes, even shifting over to a white rice rather than a brown rice to just reduce how much of that insoluble fiber can be quite helpful for the diarrhea. And then even thinking about supplementing with higher soluble fiber foods if that doesn't quite do it. So things like ground flax can be quite firming, or even psyllium powder, which is a little bit more on that supplement side if the whole foods don't quite help to balance out the diarrhea. But that's often an approach that we can help lead people through to, is experimenting with some of those fiber sources.
So we have time for one more question. Many people don't recommend milk for cancer patients. Is it correct that milk is bad for cancer patients?
Simply, I would say no. So I think this is another really big question that I get often, and it depends kind of on what kind of cancer site we're looking at. But when we're thinking about lung cancer, I don't see really strong associations through all sorts of dairy with lung cancer. And the different sources of dairy we tend to see really well supported for the lower milk fat types. And to actually break that down into real foods, I would say that's things like milk or yogurt tend to be on the lower milk fat side. We're even thinking about anywhere from a 1% to a 3% at your full fat, versus cheese that has sometimes closer to like a 50% milk fat. So you might think about maybe being moderate with your cheese intake, but if milk is an important protein source and if it's well tolerated for you, that could be, I think, a pretty reasonable thing to continue to keep in your eating habits.
Great, thank you so much, Shannon. And again, if there are any further questions for Shannon, please feel free to email them to info@lungcancercanada.ca, sorry, and we will get them answered for you.
Thank you, Michelle.
Thank you, Michelle, and thank you, Shannon, very much. I appreciate all the information. I've learned quite a bit, and I personally will be making a phone call to you folks. I've needed to speak to a dietitian for a while, so it's nice to make that connection. Our next speaker is Denise Larson. Dr. Larson leads Hope Studies Central. It's a research unit with a 30-year history in the Faculty of Education at the University of Alberta. She's a registered psychologist and former elementary classroom teacher. Her research focuses on the role of hope, along with its effect and use and benefits. And she'll be speaking tonight about research in hope. So welcome, Denise, and we're looking forward to what you have to tell us.
It's really a pleasure to be here with you this evening. I've got just getting over COVID, actually, so I apologize for the sound of my voice. I think we're good to go. So can I just confirm that you're going to advance the slides for me, or do you want me to try and throw them up on the screen here?
Yeah, I'll be advancing your slides for you. So if you just maybe
Sure.
slide when you're ready.
Okay, beautiful. Thank you. Well, you can advance to the next one, please. Thanks. So yes, I am a professor at the University of Alberta in the Faculty of Education. My discipline is counseling psychology, and I'm also the Associate Dean Research in the Faculty of Education at the U of A. If you want to just advance the slide, please. I'm the director of Hope Studies Central, which is a research unit. We've been around for 30 years. I took over from my dissertation supervisor, and we have many individuals engaged with the research. We are the only applied research unit on hope, specifically hope in practice, right? So the thing I'm most interested in is how do we use hope to live well, regardless of the circumstances that we face. So conducting research specific to therapy or counseling, individual, group, couples, the hope of the client and the counselor, looking at the hope of medical personnel themselves, looking at child and youth development, hope in the role of hope in education, and even begun looking now at how do we understand hope cross-culturally? Because we're a very multicultural country. So you can see a couple of our publications there. And if you want to advance the slide, that'd be great. Thank you. So in anticipating the talk here today, I began thinking about the kinds of things that might be questions for you as you reflected on hope. So where is hope in the face of uncertainty and difficulty? What is hope anyways? Are hope and optimism the same thing? Some people ask me, actually, isn't hope a little bit lightweight or Pollyanna? Does hope really make a difference? And is meaningful hope possible when things are tough? And if so, how? So next slide, please. Thank you. So the definition I'll offer today for this talk is that hope is the ability to envision a future in which we wish to participate. This is the definition that I find seems to resonate most with individuals who are going through difficulties in life. We have a lot of definitions that we would call academic definitions that we use to operationalize what we mean by hope and to study it. But I really like this one by Rana Jevni and Wendy Eady. And the first thing I'll note is that hope can look different in changing contexts. So you see on the left there, that kind of joyful picture of children having fun together. Hope can have this really buoyant, ebullient, effervescent quality. And we love that feeling and we know it. But that's not always how hope feels. The slide or the picture on the other side of the slide is a painting from the early 1900s by a fellow named Watts. It's a plate you'll see sometimes in art history textbooks, and is a woman sitting on top of the world, her eyes blindfolded, and it's hard to see on this slide, but a single string on that heart, kind of denoting that the one thing there is to hold on to in the face of all kinds of difficulty is hope, but it's not always easy. And we know that. This was a popular image during the First World War, I understand. Next slide. Thank you. So you'll see on the right-hand side of the slide there, I've got a web link, and you could jot that down and go to that. There are over 4,000 articles, journal articles and research articles on hope cataloged in our database. I'm just going to give you a sort of a snapshot of the power of hope, just to give you a sense of why it is that somebody like me would spend most of their life studying it. Hope is correlated with physical health, psychological adjustment, and enriched personal relationships. It is the character strength that is most associated with life satisfaction. It's a strong predictor of positive affect, so feeling good, and motivation. Hope predicts flourishing, and it's actually easier than resilience to implement. So we do a lot of work with the implementation piece where I conduct my research. Hope is beneficial in virtually every circumstance in which it's been measured physically, psychologically, and educationally. And I might just add, I don't have it on this slide, but there are interesting correlations between higher levels of hope and adherence to medical regimes as patients. So I just think that's a really fascinating piece too. There's a little image there that comes from some of our work in schools and sometimes out of the mouth of babes, right? Kids were making posters about their understandings of hope. And this youngster said, hope, sometimes that's all you have. And when you have nothing else, if you have it, you have everything. So if you want to just advance the slide, thank you. One of the questions that comes up often is, are hope and optimism the same thing? And I think this will help to elucidate some of the power of hope. I'm going to just ask you to advance the slide, please. Thank you. We won't have time to do this as a group right now, but you might want to jot these questions down and do a little experiment yourself later. 4 sentence stems: I wish, I hope, I will, and I'm optimistic about. So some researchers by the name of Brunings and Mall actually conducted this research. It's called research on folk language, because hope is an everyday word. We all use it, but we often don't reflect very much on what we mean by the term. Although I've learned that Lung Cancer Canada uses the term a lot, so you've probably given a lot of thought to it. In any case, Brunings and Mall's research suggests that we tend to wish when it's something that we're not sure about, but it is something we'd like to see happen. We'd be happy to have it happen, but we're not willing to put a lot of effort into it. One of my students, my grad students in a course that I teach on hope at the U of A said, this is like Disneyland. I'll take it if I can get it. We tend to hope when the future is uncertain, but the outcome matters to us a great deal. And so while we're uncertain, it matters so much that we're willing to behave as if a good future is possible, and we're willing to lean into it and work toward it. So therein lies the power of hope, because hope, along with holding hope, elicits that kind of energy, that forward momentum, and that willingness to commit to something that we might not know the outcome of, but we're willing to really put ourselves into. And of course, when we do that, we enhance the likelihood of good outcomes. The phrase "I will" is actually goals language, and goals are fine. We tend to set goals when we're pretty sure we can meet them. So hope lives more in the land of uncertainty, when we're not quite sure what will happen, but we're going to lean into something. And optimism, we tend to be optimistic when we assess the likelihood of a good outcome as being quite certain. So it's easier to be optimistic because we think, well, good things are going to happen. So it's something that we can be optimistic about. Hope takes us to a slightly different territory, and a territory where sometimes things aren't as easy. If you want to advance this slide, please. So with that background that I just described to you, it's a very short talk, so giving you what I can. We've conducted all kinds of research in all kinds of conditions. Where medical conditions are concerned, most of my research has been around chronic pain and Parkinson's disease. I did, however, work in a cancer hospital in Edmonton for several years called the Cross Cancer Institute before I took on this research role. So those are just a list of, or shows you some of the journal articles for the research we've done. If you want to advance the slide, please. Thank you. So as I mentioned, hope is contextual. It's also unique to each of us. So a question that I have and might invite you to think about is, do you know where you find hope? Think about the places, and these are some of the most common places that individuals find hope: with family, in nature, taking in the arts or engaging in the arts. This is very common. Being with others, including virtually, making a difference that feels worthwhile. And then you might have other ways that you go, well, like I do this and it kind of turns my crank and sustains my hope. I like to play the piano, but that's not for everybody. So one of the ways to begin to foster a sense of hope is simply to begin noticing where hope resides for you and make choices to put yourself in places and do activities that sustain hope. And I'll just get you to advance this slide, please. Thank you. So there's many ways of activating hope, and we've actually done research on many of these. So I'm going to walk you through them. They are easily accessible, and one of the things we know about hope, it's kind of like we can think of it as our hope hygiene. What have we done to foster a sense of hope for us on any given day? It's kind of like dental hygiene. We brush our teeth every day. What are we doing routinely to help foster a sense of hope? One way to do that is to make a hope collage from magazine pictures, and I'll show you something in a moment about that. Make a hope kit, take a hope walk, choose hope photos from a photo collection. A really easy way to do this is open your phone and start flipping through the photos on it and asking yourself, which of these images have I taken that are really kind of getting at what hope is for me? You might even draw hope graffiti. We saw actually a fair bit of this during the pandemic, the early days of the pandemic. If you want to just advance the slide, that'd be great. So in terms of making a hope collage, the activity is really simple. And these are examples from one of the hope groups that we run and the research that we've conducted on it. Individuals just take 2 hours with a pile of magazines and go through magazines looking for images that symbolize hope for them and collecting them into a collage. And it is not about the beauty of the pieces, though I think they're lovely. It is really about spending 2 hours focused on thinking about hope and what symbolizes hope for you. In the chronic pain group, we found people became so fixated on doing this, they lost all measure of time, and we'd actually have to invite them to get up and move around so that they didn't get too stiff and find it too painful. But what we noticed is that the activity itself just magnified hope, and when the group members shared their hope collages with one another, it just really amplified that sense of hope. Next slide. So when I talk about hope graffiti, these are the messages that people tended to leave for one another on sidewalks or on posts or in their living room windows. During the pandemic, this is a fun way to get out and share hope with others, and it gives a kind of a buoyed sense to oneself. I have my students doing this around our ed buildings during exam week, offering hope to their fellow students. An easy one is just to take a walk with the intention of looking for hope, and you can even take photos of anything that symbolizes hope for you as you go. You may know why it symbolizes hope, or you may not. You don't actually have to be able to put words to it. There is something that happens when we change our lens and kind of don hope glasses and begin looking for it. We begin to see it in all kinds of places we mightn't have thought in the past. Next slide. And then this is the last activity for finding hope. And it's one that you'll have to practice at home. But drawing your attention to instances in your life where the possibility exceeded your expectations. So a time when something turned out better than you expected. And we have all kinds of these in our lives. I'll tell a very short story just to give an example. I'd been working at home one winter morning and was going into the university to teach. And I looked out and the snowplow had gone by my street and blocked me into my driveway. I thought, I am so hooped. I am not getting in there to teach. And lo and behold, I looked down the street, found the snowplow driver and was able to get him to come down and open the driveway up for me. I actually made it in time. A small example of a time when something turned out better than I expected. Next slide. You will have all kinds of these in your own experience. Let's just skip that slide just in the interest of time. And I would just invite you to practice sharing stories from your work life or the rest of your life where something turned out better than you expected. They can be tiny little stories like the snowplow stories or something really big. And you might even, after each story, want to write a statement about the hope lesson that you learned from that story. The interesting thing is that when in groups we start telling these stories, the more stories we hear, the more we think of from our own lives. And these are ways of fostering a sense of hope, and I'll talk about that very briefly in a moment. Do you want to transfer or move this slide forward? Thank you. I call these hope axioms. Axioms comes from math, and we're not talking about math here, but the definition of an axiom is a self-evident truth. And really what we're doing is looking through our past and excavating sources where we have personal evidence that there's reason for hope because we've experienced good things in the past. So if you want to just forward the slide, please. And this is the last piece of research that I'll share with you. A master's student of ours did a really fascinating study looking at using what was called Zimbardo's time perspective scale and a hope scale. And hope is future oriented. I just told you that at the beginning of the talk. And so we anticipated that people who were higher hope would, or higher hope would be have a future time perspective, a positive future time perspective, because they're oriented towards the future. What was fascinating is that the strongest correlation between time perspectives and hope was for those who have a past positive orientation to life. So are able to look at their experiences in the past and see a hopeful future for themselves. And this isn't terribly surprising for those of us who are engaged in doing therapy. We all have stories that have been difficult, and we all have stories where things went well. And sometimes it really benefits us to think carefully about, like, when were the times that things turned out well for me? And to begin sharing those stories, because it can tilt or orient us in a more positive way towards the future. It's that there's evidence of hope in the past, or evidence of good things in the past provides evidence for the possibility of good things in the future. So just forward the slide. Thank you. So the list of possible hope techniques that you could take home and experiment with and try. Notice what you notice. Are you paying attention to hope? How do you want to orient to hope? Choose to notice hope. You could decide to get creative and go and do hope graffiti if you're feeling fun and playful. You could take a hope walk and photograph hope on your walk. And this does not have to be a big walk. It could just be out your front door and down the street. Make a hope collage. Try making a hope collage and put it up. You know, if you make one, where do you want to put it to remind you of hope? Or practice telling hopeful stories, a time when something turned out better than you thought. Next slide. Here are a list of some resources that you might find helpful. You can go to our Hope Study Central website. There's a little book there that Rana Jevni wrote. I'm not selling them. I don't make any money off of them, but I do believe it's available on places like Amazon if you're interested. A good colleague of mine, Wendy Eady, maintains a blog. And I'm in Alberta, so I put the Alberta Health Services mental health resources. You could access them, I'm sure, from anywhere. And then next slide. And that's it. Thank you very much. I really appreciate the opportunity to be here with you today and to share some of the work that we've been doing. And I'm not sure what time is like, but I'd be happy to take a few questions if there's time. Oh, that's a spare slide in case we get a question about hope across cultures.
Thank you so much, Dr. Lawson. I know there's definitely some things that I will be trying to do in the future. Is there any questions for Dr. Lawson? Please put up your hand if you'd like to ask or put your question in the chat.
I see Stephanie's comment, and you are most welcome. It's a real pleasure to be here with you today, Stephanie.
All right, thank you so much. Stephen, I turn it over to you.
Thanks very much, Michelle. And thank you very much, Dr. Larson, for bringing forward all these ideas and how we can develop hope. It's certainly something that challenges us as cancer patients and something we work on a daily basis, I think. Sometimes we don't even know that we're working on it. For some, it's very easy. For some, it's not easy at all. But you've brought forward wonderful resources, and we so appreciate this. I think at this time, we're pretty much finished up for our evening. So I would like to thank, first of all, our speakers, Dr. Stephanie Snow, Ralph Gouda, Shem Singh, Dr. Paul Wheatley Price, Shannon Smith, and Dr. Denise Larson. I also would like to thank our program sponsors once again. That's Amgen, AstraZeneca, Bayer, Bristol Myers, Squib, EMD Serono, Jazz Pharmaceuticals, Eli Lilly, Merck, Pfizer, Roche, Sanofi, and Takeda. I hope this has provided all of you folks with some hope and inspiration. And thank you once again, one and all, for attending this evening's Patient Summit.